Okay, good afternoon, everybody. Please enter roll number. If you are attending online, please send your roll number. We will also be taking a picture at some point of time during the lecture and identify people by their faces who are online at that point of time. So stay throughout the briefing. Okay, today we have three briefings. Adolescent interventions, adult interventions, and then how to plan and implement your interventions. You already had classes on family interventions and child interventions, right? Right? So we are going to cover adolescent and adult today. And then finally, how do you convert your theoretical knowledge into an intervention plan? Right? So I will tell you how to convert it into a plan. Dr. Ravneet will tell you more about the technical part of the planning of the adolescents and adults. Right? So basically, all of you have been given a family with an index case, either a child, adolescent, or an adult. And what we expect you, based on your assessment that you have done, you prepare an intervention which is specific to that person and that family. And then monitor in the end what happens. So how do you plan? Right? So what is to be done? Basically, you want clearly that you want the person to reach from position A to position B. For example, this could be blood pressure. You want his blood pressure is 180 by 120, you want that person to reach by 160 by 110 or whatever. Right? So first is to fix a point and then decide how will the journey be done from point A to point B. What needs to be done to reach from point A to point B? And who will do it? Any plan, you have to be clear. ये करना है तो किसको करना है, कैसे करना है, क्या रिसोर्स चाहिए, वो रिसोर्स कहाँ से आएगा. That's how we all plan. No? Whenever we plan our holiday, that's how we plan. भाई किस किस को क्या क्या लाना है, कौन ये लेके आएगा, कौन दूसरा लेके आएगा ना, कौन बियर का इंतजाम करेगा, कौन स्पीकर का इंतजाम करेगा, मतलब राइट. So something like that you have also to do. When will it be done? Because time frame, we are working on a time frame. So obviously you are not working in a कि हम 2 साल में जर्नी नहीं ट्रैवल कर सकते. हमको लाजमी 2 महीने में जर्नी ट्रैवल करना. तो 2 महीने में जर्नी ट्रैवल करना है तो हमारा जो पॉइंट है तो फिक्स है. आप असेसमेंट बता रहे वेदर ओबेसिटी वेट है या बीपी है या ब्लड शुगर है या बच्चे का वेट है, राइट, दैट इज फिक्स्ड. Point B is up to you. Given that you have 2 weeks time, and I have said this earlier also, don't be too ambitious. Be realistic. तो point B आपको जरूरी नहीं 180 से 120 पे लाना ना, 180 से 160 पे लाओ, क्या प्रॉब्लम. Point B तो आप डिसाइड कर रहे हो in consultation with the patient, right? What is feasible based on assessment till now. So target जो है आपने फिक्स करना है इन कंसल्टेशन विद द सब्जेक्ट. सो दैट इज द मोस्ट इंपॉर्टेंट थिंग, द पार्ट वेयर यू वर्क विद द पेशेंट. You are strongly discouraged to impose your plan on the patient. You are strongly encouraged to discuss your plan with the patient and arrive at a mutually acceptable plan. There is no good bad plan, there is no right wrong plan. Any plan that the patient is willing to implement is a good plan. And its success depends on whether it was implemented. Whatever is decided. भले आप ये मत सोचो कि वो दिन में 1 घंटा वॉकिंग करना शुरू करेगा, आपके कहने से नहीं होने वाला. आप 20 मिनट बोले 20 मिनट चाहिए तो you're successful. Rather than his zero now and you say I will make him walk 100 minutes a day and don't achieve it. 2 महीने में नहीं हो सकता. The general thinking is that if you put the patient on a path to do these kind of a thing, he walks 20 minutes today, tomorrow he finds it convenient, he will increase it to 30 minutes. He will go to 100 minutes also. Right? Your job is to put him on the path. Do not necessarily have to reach the destination. उसका destination बहुत लंबा है, chronic disease है. उसका जर्नी का destination 2 महीने में नहीं खत्म होने वाला, वो जिंदगी भर का जर्नी है. If you put, your job is to put the patient on the right path in that journey. यदि गलती रास्ता लेगा तो कहीं और ही पहुंचेगा. यदि तुमने सही रास्ते पे डाल दिया, स्पीड उसकी मर्जी है. मैं यहाँ से हरिद्वार जाना चाहता हूँ, पैदल भी जा सकता हूँ, मेरी मर्जी है, साइकिलिंग भी कर सकता हूँ, आई कैन एंजॉय साइकिलिंग. Somebody may want to drive and in expressway drive 120 kilometers on. सबका अपनी अपनी मर्जी है. Speed is not entirely up to us. It is patient has to do it. तुमने नहीं करना है, जो चीज तुमने करना है उसको टाइम से करो, पेशेंट अपने टाइम से करेंगे. Don't expect them to hurry things just because you want to show a good performance to us. That is not the purpose. We are not judging by your performance. We are judging by patient's performance. They have to comply to your advice. So that's the most important thing you have to understand. So you might fix for diabetes and blood sugar or an HbA1c cutoff as your target that you want to achieve in 2 to 3 months time. ये जनरली हम लोग पहले सब जो है हम we are still not sure about the vacation and how much of this will go beyond vacation. If it goes beyond vacation, you will get a longer period of time. Our general approach would be to finish the intervention before the vacation. एक रिव्यू कर लो और फिर 2 महीने दो for a final impact of the intervention. That's what our aim to do, right? Within the, so that you are already by say April end your interventions are in place. Give another visit for you to go and check whether they are actually following you, उनको कोई problem आ रहा है कि नहीं. And then if vacation is there, you will get it 2 months break. और यदि आपने सही रास्ते में डाल दिया है तो 2 हफ्ते में 2 महीने में, और that person should have made the journey further down the road. Then what we assess at the end of middle of May or something like that, right? So if you want, for this is an example, if you want to control blood sugar, you might want to change the dietary habits. You might want to increase physical activity. You want to review the treatment. उसको जो दवाई मिल रही है, do we need to review it? Do we need to change medicines, increase whatever, replace and improve adherence? Largely हमारे behavioral interventions है और treatment interventions जो है revise the treatment or and improve adherence, right? This is the strategy. Our strategy is going to be this, for example, right? It could be more than this also, but minimum है ये. इतना तो करना ही करना सब. अब other things that exact details of the review will tell you later on. What we will make change. But आपको जैसे कुछ ये है, again हर पेशेंट में सब कुछ करना जरूरी नहीं है. Again, don't be too ambitious. First is, it not all is required in all patients. Number 2, there will be something which is more important for this. Focus on something which is more important. Don't focus on everything. Don't think within 2 weeks or 1 month you will change. There's decrease in salt, decrease in fat, decrease calorie, free sugar, fruits and vegetables. Because diabetic है, so maybe focus on free sugar and maybe fruit and vegetable. That might be priority over the others. Hypertensive है, so salt and fat might be more important. Again, this also depends on your baseline assessment. यदि baseline वो चीज already अच्छा कर रहा है, तो आपको introduction की जरूरत नहीं है. So choose based on biological need, physiological need, and patient's current status. Choose a strategy which is doable. अब fruits and vegetables, अब आपको सोचना पड़ेगा. This is what we say. You have to do some sort of micro planning. जनरली आप एडवाइस करते हैं भाई इंक्रीज फ्रूट एंड वेजिटेबल. ये एडवाइस बिल्कुल मीनिंगलेस हो. So you have to work with the patient to see how it can be increased. Where is the space within the patient's diet where you can increase the fruit and vegetable? सुबह खाए, शाम को खाए, क्या खाए, इसका कॉस्ट क्या है? Will the patient be able to afford it? अच्छे जाके बोलोगे तो तुम अंगूर खाया करो, और what obviously diabetes will not do this anymore. But there are low cost vegetables, right? Pear है, पपीता है, relatively, obviously all fruits are talking about in a relative sense. There is nothing to indicate that they are worse off than the bitter, so-called more glamorous fruits. Less glamorous fruits are as useful as more glamorous fruits. Obviously, taste सबके अपनी इस पे है. So identify, talk to the patient. क्या उसको पसंद है, कौन से फ्रूट बढ़ा सकते हैं जो अफोर्ड कर सकता है, जो उसको एक्सेप्टेबल है. दिस इज अ कन्वर्सेशन यू हैव टू हैव. डोंट इंपोज योर थॉट्स. बोलो जी हमने देखा कि आपको फ्रूट कम खाया है, अब बताएं फ्रूट कैसे बना सकते हैं, सब्जी कैसे बचा सकते हैं, कौन सी सब्जी अवेलेबल है, इसमें आपको क्या पसंद है, वेयर विल यू फिट इट विद इन द डाइट. दिस काइंड ऑफ माइक्रो प्लानिंग हैज टू हैपन इफ योर प्लान इज सक्सेसफुल. अदरवाइज यू जस्ट से ईट फ्रूट, बोथ फ्रूट्स एंड वेजिटेबल्स, It is doomed to failure. There is no question of it being successful. Okay. उसका कॉस्ट देखो, पता करो कॉस्ट क्या आएगा. Can it be? Do they have the necessary elasticity within their income to fix it, or it needs to किसी और चीज को कम करें, इसमें ज्यादा करें, right? Maybe reduce some junk food, ask them to spend more on healthier food, right? Those kind of thinking, again, unless you know them, unless you have discussed with them, this is not going to happen. And you might want to know other members in the house. Ultimately, diet is not an individual's choice. That पूरे घर वालों का बनता, फ्रूट सिर्फ उसके लिए तो आएगा नहीं, बाकी लोग ने भी खाना है, उसके खाने में सिर्फ नमक कम नहीं करूंगा, सबके खाने में नमक कम करना पड़ेगा. So you cannot have a diet conversation in a house without involving other members, especially the person who cooks or buys the provisions, right? So they have to be involved in the decision. And you can identify a person in the house who is going to push this agenda. जिसको जो बच्चे भी हो सकते हैं, ग्रैंडफादर है तो children can be motivated by तुम रोज दादाजी को या नाना जी को एक केला खिलाओ या एक, they might take it as a challenge and might do it. You might get it implemented, right? They might persuade their grandchildren. So identify somebody in the house who is likely to be able to influence the person to change the habit. Same is true for physical activity. So वैसे ही आप सबके लिए कर सकते हो. यदि आपको फिजिकल एक्टिविटी करना तो हाउ वुड यू यूज द सेम लॉजिक इन फिजिकल एक्टिविटी? कैसे करोगे फिजिकल एक्टिविटी के लिए? ऐसे जैसे मैंने 5 पॉइंट इसके लिए लिखा, वैसे 5 पॉइंट फिजिकल एक्टिविटी के लिए लिखना, तो क्या 5 पॉइंट? सॉरी, so one is what type of physical activity? Is it walking? जैसे आपने टाइप ऑफ फूड्स बना, इसमें फिजिकल एक्टिविटी के बहुत तरीके हैं. वॉकिंग इज द कॉमनेस्ट. There could be others. Gardening could be, depending upon the age and other things, could be going to a gym. Adolescent के लिए going to a gym हो सकता है, for example, right? Jogging हो सकता है. फिर मान लो वॉकिंग करते हुए, that is going to be at most likely. What else? So here again, if you say walking, how do they get walking time in their daily routine? One could be बच्चे को छोड़ने जाते हैं, उसको चले जाओ, बस स्टैंड चले जाओ, या सब्जी खरीदने जाते हैं. If they do it, if they don't do it, it is not there. You could also add it as a, सुबह बैठ के कुछ करते नहीं है तो इसके लिए added activity also, not necessarily always an activity which is converted activity. It could be a new activity also, which the timeline, especially for elderly, it might be available. What else? Yoga is a type of activity, but largely we don't treat yoga organized or physical activity of company. What else? If you want somebody to do physical activity, which type of activity? How do they fit it within the routine? What else would be important? Think about yourself. यदि तुमको कल सुबह से फिजिकल एक्टिविटी के लिए आधे घंटे के लिए जॉब के लिए जाना है, तो क्या करोगे? What will make you go do that? जोर से. अभी हम लॉजिक विचार करें लगता है कि साइकिलिंग हो, बट लेट्स से यू वांट टू डू जॉगिंग, यू वांट टू डू जॉगिंग फ्रॉम टुमारो मॉर्निंग. तुमने सोचा मुझे जॉगिंग करना, तो व्हाट विल मेक यू डू इट? तुमने आधा घंटा निकाल लिया, तुमने सोच लिया, इज दैट एनफ दैट यू विल डू? या जॉगिंग क्लास वगैरह की ऑलरेडी अनदर पर्सन हो सकता है, हस्बैंड वाइफ दोनों मिलकर जाए, या बच्चे के साथ जाए, या नेबर के साथ जाए. फाइंड अ पार्टनर. कोई भी आदमी अकेले जाने से हिचकी करता है, एक और पार्टनर ढूंढोगे तो इज मोर लाइकली टू डू इट, एंड दैट्स आल्सो मोर लाइकली टू मेंटेन इट. वो तो किसी दिन आलस हो जाएगा, छोड़ो यार क्या आज मैं नहीं जाता, तो इसके और को होगा तो बेटा नहीं चल मेरे साथ चल, खींच के ले जाएगा. So finding somebody else is a very important strategy for people. अकेले कुछ दिन करेंगे उसके बाद छोड़ देगा, बोर हो जाएगा. So think of these kind of details. So you have to find out when maybe आपको जाना है तो किसके साथ जाना पसंद करोगे? Will the wife go with her? Wife will say नहीं जी मेरे को तो सुबह किचन में काम होता है जी, खाना पैक करना होता है, बेटा जाता है ऑफिस. She may not be able to. Or you find a time which is suitable to do. There is no right answer for it. Any answer which you found with them is the right answer. तो बोला कि 9 बजे के बाद चले जाओ, यदि ऑब्वियसली टुडे विद सनी दैट डू अर्लियर इन द डे, शाम को चले जाओ. Same thing you can do for salt, same thing, anything that you think, but you have to do this kind of micro planning with the patient, and that is why the plan would be individualized. There is no generic plan. You cannot cut and paste this plan to your plan unless you have discussed it with this subject. हर एक का अपना चॉइस होगा, अपना पसंद होगा, अपना टाइमलाइन होगा. सिमिलरली बच्चों का ऐसे ही है. Especially if the child is malnourished, we don't expect suddenly the child to start eating double the amount. So you have to prepare. अगले 1 महीने में इतना बढ़ेगा, उसके 1 महीने बाद इतना बढ़ेगा, उसके 1 महीने बाद 3 महीने में इतना बढ़ेगा. So same thing, make incremental changes over time. Increase number of meals than amount per meal, and use food products as such which किसी भी dietary advice के लिए valid है. Look at cost, convenience, etc. Same is true for whatever practices that you are doing. So again, as I said, हम प्रायोरिटाइज कैसे करेंगे? जैसे आपको 5-6 चीज करनी है. There are 2 ways to do it. Both are correct. Ultimately, you will choose a compromise. From your assessment, what do you think is most important, which will determine the outcome? Right? For a hypertensive patient, it could be salt consumption, it could be complete lack of physical activity, it could be tobacco use. Right? दूसरा, पेशेंट या फैमिली का पॉइंट ऑफ व्यू से वो क्या करना चाहता है, पेशेंट क्या करना चाहता है. You should give primacy to that, even if that leads to a lesser impact. Because patient will gain confidence. जो हम बोलते हैं सेल्फ एफिकेसी, जो चीज पेशेंट करना चाहता है वो करेगा तो उसको कॉन्फिडेंस आएगा कि मैं कर सकता हूँ. Then tomorrow he might be willing to try out a more difficult intervention after gaining confidence. Because straight away smoking is not that easy to identify that patient will see कि मैं तो कुछ नहीं कर सकता. So I try living again start and he will then think that I cannot do anything. मेरे बस की नहीं जी, मैं कुछ नहीं कर सकता. So repeating same, there is no right or wrong. Conversation is the most important thing. बात करो, जो भी फैसला है उसका एक्सेप्ट करो. Don't try to impose your thought on the patient. You are doing it for patient good. ऊपर से imposition से नहीं होता. Patient को कि knowledge बढ़ाओ, let it come from the patient. Right? Then as I said already discuss with people. So आज डिस्कस किया, फिर घर जाके एक प्लान टाइप का बनाया. अगले विजिट में उसके साथ डिस्कस किया, जी हमने फैसला किया था इसमें से, और ये अब हम सोच रहे हैं कि आप उससे राजी हो कि नहीं. वो पता नहीं थोड़ा कि आधा घंटा नहीं चल पाऊंगा, वो 20 मिनट ही चल पाऊँ. हैव अ कन्वर्सेशन. इफ यू कैन कन्विंस हिम कि नहीं 30 कर सकते हैं तो 30 रहो, वो नहीं कन्विंस कर पाते तो 20 कर लो. ठीक है. So a practical plan is more likely to succeed than an ideal plan. You are just a catalyst. तुमने धक्का मारना बस थोड़ा होगा. And then obviously you have to monitor. Any plan will succeed only if you monitor it. यदि प्लान करके भूल गए, मैं भी भूल गया, आप भी भूल गए, तो फिर तो छोड़ सकते हैं ना. So you have to be clear what to monitor. Again, there are too many parameters that you are doing in baseline assessment. सबको monitor नहीं कर सकते. So you can identify 2 or 3 critical based on your intervention. Your physical activity is the intervention, in physical activity को monitor करना पड़ेगा. Salt है तो salt का monitor करना पड़ेगा. Obviously अगर outcome monitor करोगे, blood pressure, blood sugar का तो monitor करोगे ही करोगे. तो मेरे न्यूट्रिशन स्टेटस बच्चे का तो करेंगे ही करेंगे. तो क्या पैरामीटर है, उसको कैसे नापोगे, कौन नापेगा. फॉर एग्जाम्पल यू कैन, ब्लड प्रेशर है या ब्लड शुगर भी है, लेकिन मैनिपुलेट बोथ इफ दे हैव टू मशीन, और दे कैन गो टू द डॉक्टर इन द एरिया एंड गेट इट मॉनिटर्ड. यू मे नॉट बी ऑलवेज बी एबल टू डू इट. इफ यू वांट अ मोर फ्रीक्वेंट मॉनिटरिंग, यू माइट आस्क देम टू डू एंड गेट इट डन फ्रॉम आउटसाइड. तो आप खुद ही कर सकते हैं. एंड One important intervention, especially for NCDs, could be if you can teach them to keep a diary of record. It's a lifelong use. यदि उनको बना देंगे कि इस दिन ब्लड प्रेशर या भले खुद लिया हो या बाहर जाके गया, आप घर आके डायरी मेंटेन करें, इस तारीख को मेरा ब्लड प्रेशर इतना था, इस तारीख को इतना वजन था. If they can maintain just that simple diary or blood sugar, it is of enormous use for chronic disease, right? So again, there are some possible parameters. So I think this is what how you will record them, depending upon what parameters you choose. हर एक visit का measurement का डेट डालोगे और पैरामीटर जो भी था, बीपी था तो बीपी वैल्यू लिखोगे. When you make your final presentation, you will show it as a the number of measurements we have shows that you have made more effort. If there are only 2 measurements at the beginning, at the end, that means you have not monitored it effectively. The actual value is not a function of monitoring. कितने बार measure किया वो monitoring अच्छा हुआ या बुरा हुआ. Actual value may go up, down, whatever it is. And if we can present it as we do for the simplest way that we present monitoring of weight is by growth chart, right? That tells us a lot of things. So growth chart is a pictorial presentation. You can make the same for hypertension, diabetes, and use it to educate your patient. आपका पिछले साल महीने इतना ब्लड प्रेशर था, आप देखिए ऊपर चला गया है. So if they keep a diary record coupled with a pictorial representation, can be useful for patient education. So have you understood how to plan and monitor? The actual contents, what you should tell, technical part of it, now Dr. Ravneet will take. You have any questions at this stage? So again, for people online, stay online, send your roll numbers by message, SMS, and we'll take a photograph of the screen at a later stage. Thank you. Okay, thank you.
So now we've just discussed the implementation plan. Let us discuss the interventions one by one in detail. We need to implement these interventions. So first of all, let us discuss the adult case. All of you have got an adult case in the family, and as you know, this is a matrix of the FHAs. We first do the assessment, then intervention, and then we are going to measure the outcome. So this component, all of you have, I hope, completed the assessment part. All of you have completed the assessment part. So when an adult patient was allotted to you, the assessments that you were required to do were the risk assessment, the diet assessment, the physical activity assessment, as well as the inthropometry. And similarly, if the patient is suffering from hypertension or diabetes, you would do evaluate the current status of the disease, the quality of care, whether it is as per the guidelines or not, if it is hypertension or diabetes. Then we have to measure the adherence to key medicine, knowledge of the disease, and cost of it. Now, based on these, you will identify one area for intervention. Right? As I was saying, that we cannot achieve everything. Whatever is relevant to your case, it may be different for each one of you. All of you would not find the same gap on the assessment. In some patients, it might be adherent. In some patients, it might be diet. So, according to your the case allotted to you, you identify the area for intervention, right? So it will be primarily our intervention is behavior change. What we want to achieve is behavior change. Our intervention would be targeted for behavior change. Now, as I told you, we will identify one key risk behavior. It may be diet, it may be physical activity. Based on that, we will prepare a revised diet or physical activity implementation plan. One outcome deliverable is a development of an education pamphlet. You will have a full session on how to develop a pamphlet. The expected outcome is like as you will give the intervention, then you will monitor it, and in the final stages you will measure how much effective your intervention has been. So it will be in the form of It may be a change in diet or physical activity. It may be change in adherence. It may be reduced cost of treatment. Maybe change in anthropometry. You may not be able to witness this because change in anthropometry takes a relatively longer time. While behavior like change in diet and change in physical activity may be possible within your tenure, you may not be able to see change in anthropometry. You may or may not be able to see change. So finally, the impact that we expect is a reduced composite risk and better disease. Now have a look at it one by one, what all interventions can be. So key components of interventions would be, if it is a patient, you want that the disease be managed in a better way. It can be adherence to medicines, self-monitoring and record keeping, and behavior change in relation to diet and physical activity. So what are the interventions for disease management? We would like to see whether the treatment that they are taking is appropriate. So if a patient is having hypertension, he has been given some drug, we want to see whether this treatment is as per the guidelines and it is appropriate or not. We also would like to reduce the medicine load. Only those medicines which are actually required. The cost of treatment we wish to reduce, and ensuring good quality of care, including the investigations. So all of you are expected to read these two documents. One is the ICMR guidelines for management of type 2 diabetes, and this is a module for medical officers, population-based screening for non-communicable diseases. It will be included in your assessment. When you take your test, we will have questions based on these two in addition to your FHAs. Also read about the medicines mentioned. You have already done your pharmacology. Whatever drugs are there, you are expected to be aware of the doses, the contraindications and side effects. What combinations would work, what are contraindicated, you are expected to know that also. Now, this is about this is the algorithm for use of anti-hypoglycemic agents, for the management of diabetes. So if you have a patient of diabetes, these are the symptoms that you would look for. First of all, lifestyle modification. These are the interventions. Why I am showing you this? So that you can decide which intervention you are going to do in your patients, right? So if the HbA1c is less than 9%, we'll add metformin single therapy, right? But if it is more than 9, and if the patient is symptomatic, consider insulin. If the patient is asymptomatic, consider to add one more oral hypoglycemic agent. Fine. If HbA1c is not a target, I will show you what is the target HbA1c, what is the level of control. Less than 7, usually we consider that it is good. We continue to monitor if it is achieved. If it has not been achieved, then we will add one more oral hypoglycemic agent. Or if it is still not controlled, then we will add insulin. Okay, so this is the algorithm for management of diabetes. So you can monitor how is the treatment, is it appropriate, is it controlled in the patient that has been allotted to you. Fine. So these are the targets for metabolic control. You can use these investigations to actually see what stage your patient is in. If, as I told you, HbA1c is less than 7, this is the anthropometry. Waist circumference in men less than 90, in women less than 80. Target BMI ideal is 20 to 23, but if it is 23 to 25, it is satisfactory, and unsatisfactory is more than 25. BP measurements, as you know, ideal is less than 130/80, or satisfactory would be less than 1. So fasting plasma glucose and 2 are postprandial glucose. So this we can use to monitor. Now we can assess the level, like all of you have already interviewed the patients. Have you done risk assessment also? Are you aware? No? Could you identify what is the level of control in your patients, or you are yet to do this? It was supposed to be done in the last visit? Okay. So, right. So, in order to plan your interventions, you have to do this risk assessment. So, if it is a patient of diabetes, you will ask for their records and you will see how good their HbA1c is, what treatment they are taking, is it appropriate or not, is it controlled or not, and then you will plan. And this is the lipid control for diabetes. Similarly, for hypertension, this is the algorithm. So first of all, our target should be less than equal to 140/90. Okay? And if it is more than 60 a BP of 150/90 is the cut. So we will initiate the lifestyle changes, you already know, avoid alcohol, high salt, encouraging fruit, vegetables. And then as a first step, we initiate treatment with A or C or D. Okay? We'll see calcium channel blockers, diuretics, and ACE inhibitors, right? But if it is stage 2, then we'll initiate with 2 drugs. We'll review after 4 weeks. If it is continued, then we'll review after 3 months. So this is how we are going to follow it up. If it gets controlled, then we continue with 1 drug. If not, we consider adding beta blockers or other vasodilators. But if it's still not controlled, we'd like to refer it to a specialist's care. And if it is controlled, then we keep on giving that medication and review after each continuous BP. So this is just for your reference, just to see whether the treatment is appropriate and adequate, what all drugs they are taking, what is the initiation dose. So if you have a patient with hypertension who is being allotted to you, do risk assessment. Whether so the aim, the treatment goal is to obtain a blood pressure of less than 140/90. For those with diabetes, we would require a more strict control, 130/80. And as I already told you, patients who are 60 years or more, who do not have diabetes or chronic kidney disease, the blood pressure level which is targeted is less than 155. Now that you have assessed the treatment and you see that you need to modify that treatment. So what are the tips that we will use to modify the treatment? Before you add a second dose, first reach the highest allowed permitted dose of the single medicine. Okay? Then if you have to add a drug which has a different mode of action. It's not that you add 2 calcium channel blockers or you add 2. So add a drug that has a different mode of action. Now there is a term called therapeutic inertia. It means failure to advance therapy or to de-intensify therapy whenever. Now you also rationalize the treatment. Look for the possible fixed dose combination to reduce the medicine. If a patient has to take 3 pills, it will be difficult for him to take these 3 pills at twice a day. So we can consider fixed dose combination so that the patient has to take only 1 tablet. Try to reduce the cost. Adherence is more likely to be maintained if it is cost effective for the patient. Use generic drugs. Prescribe those drugs that are available from the US. Then you can expect better adherence. And if a patient is taking, expensive drugs, fancy trade names, you can actually replace them with cheaper alternatives if they are available. And sometimes we see that patients are taking, unnecessary treatments like they take omeprazole, pantoprazole, they take antacids, vitamins all the time. So if there are some unnecessary treatments which are not required or going on, stop those unnecessary treatments. And whatever you are doing, it was told in the previous session also, explain to the patient, talk to the patient, counsel them why you are stopping this, what is the change that you are going to make, why you are making that change. So you just cannot make the change and go away. You have to explain to the patient what you are. Now, if you have a patient of diabetes, so you want to see, you will do the risk assessment, you want to identify your points for intervention. So we have certain diabetes quality of care process indicators. इसका साल में एक बार ही कम से कम HbA1c होना चाहिए and at least 1 NPS. And at least 1 test for microalbuminuria. dilated eye examination, at least 1 foot examination, and smoking status at certain and documented. Why do we want to have this? ये क्यों कर रहा है? LDL cholesterol, microalbuminuria, eye examination. What is the purpose of doing this? Sorry? Yes, the last one, Mr. Mobile. Constantly on mobile. बाहर जाते थे कि इतने लोग नहीं आए, आप भी आते थे क्या करोगे? क्यों करना है? Why do we want to do all this? आपका क्वेश्चन हो गया? Doing all this. Patient को क्या explain करोगे खुद ही नहीं पता. And then your intervention will fail. Similarly, we have these people. Smoking failures we have to be certain. The patient should have received at least the following lifestyle advice. Prescribe at least one medicine and regular blood pressure once every 3 months. Now, if your intervention is to improve quality of care, we will see what has already been done and we will review the records. These investigations, which we just said are important for identifying the appropriateness, we see whether they are done or not. Educate the patient for regular testing and its utility in the management of the disease, and ask them to have a discussion with the treating doctor. Now, most of these patients might not be getting treatment from the UHC. They might be going to some other physician. They might be going to another, maybe a private clinic or a government. So if they're already on treatment, you should not interfere too much with the management that is going on, with the therapy that is going on. Only try to cover those key points like, not stop unnecessary medicine, give cheaper alternatives, write the medicine which is available from the government system or free of cost. But don't try to change the entire. Next intervention maybe. So one of the, if you find in your family that the treatment was not appropriate, your intervention would be disease management. It may not be there in some of you who so you may not require to change. You will find some other behavior. So it may be the plan is ready. Doctor already has the guidelines, but the patient is not helping. So now our plan is to identify that in our patient the treatment is right, but the patient is not. Now our focus will shift on how to improve in my patient. So, कैसे assess कर सकते हैं adherence? How can we assess the adherence? We can ask the patient, आप रोज दवाई लेते हैं नहीं लेते हैं या कभी कभी भूल जाता है, so it would be self-reported. We can do pill counting and modified bone hill criteria. Have you read your FHS manuals? What is bone hill criteria? Who will tell? It's written in your FHS manuals. क्या होता है bone hill criteria? What is the numerator? What is the denominator? Anyone? Any one of you have your manuals with you today? You have the manual? देखो कहाँ लिखा बोन हिल क्राइटेरिया. Yeah, read it aloud. What is boon hill criteria? Read it out aloud. Area? What is it written? Read it out. Okay, last, tell me the last. The proportion of tablets is taken out of the tablets that you expected. How many times you took? When will you purchase? Then you will ask those questions. Okay. If the adherence is good, then you will give a positive reinforcement. You will praise, you will appreciate, and tell them to continue what they are doing. So praising is very important. You have to appreciate the person, the good that they are doing. If poor adherence, you have to identify why the adherence is poor. Is it unintentional or intentional? Sometimes it is unintentional. The patient may forget. Sometimes it is practical issues that the time is not there. They have to go quickly. Sometimes the doses are so complex. 8 बजे खाना है, 2 बजे खाना है, फिर 5 बजे खाना है. So the dosing schedule is very, very complex. Sometimes they take it very lightly. They take it casually because even रोज तो खाना एक दिन नहीं खाएंगे तो क्या हो जाएगा? They don't know that there may be complications. So it may be lack of complications. So this is unintentional. But sometimes it may be intentional. So they don't want to take too many medicines. They think there will be a lot of side effects and high cost of treatment. बहुत महंगी आती है, हम तो ले नहीं सकते, इसलिए कभी-कभी छोड़. Do you think the intervention will differ in these two types of adherences? But your intervention will definitely differ. How will it differ? Now just let us see. Counseling for adherence group. So missed doses, as we said, they are away from home, they are too busy, they slept in, side effects, did not understand the instructions. In many patients of hypertension, what we say, उन्होंने 1 महीने का दवाई दिया था, फिर हमारा ब्लड प्रेशर ठीक हो गया, उसके बाद हमने दवाई दी. And will end up in complication. The most common cause of chronic kidney disease is uncontrolled hypertension. And we have come across such patients who did not take medication because they did not come for. The follow-up instruction was not clear. Right? They didn't know they have to take it like for a lifetime. Right? And this. Now, now that you have decided to improve the intervention, there can be various interventions to promote. We can simplify the regimen, adjusting time, frequency, and dosage that suits them, matching to the patient's activities of daily living. Using adherence aids, I will show you, such as medicine boxes and alarms. For those who don't have enough knowledge of complications and why they should be taking the medications regularly, distribution of written information or pamphlets, telling them to access health education which is available on the internet if they use internet. Otherwise, you can tell them through a pamphlet or by advice. Modifying patients' belief. You have to tell them that they are at risk of complications. What is the severity, right? And you have to, impart your messages as per the patient's level of understanding. You have to come to the patient's level of understanding. You cannot use your medical jargon. आप उनको नहीं बोल सकते कि आपको retinopathy हो जाएगी, आपको, right? You have to tell them in their own language what will happen if they do not continue. Then role of family is very important in adherence to medication. Do you agree? Is there a role of family in medication? So you can actually include a patients in decisions. You can involve a family member. Sometimes it's the daughter, sometimes son or daughter-in-law is the caregiver. If somebody reminds you, आपने वो दवाई खा ली क्या आज की, तो it might help. So we can involve one family member to actually help them to adhere to the medications. And then we can evaluate, like as was told you in the last session on implementation also, they can maintain a diary. It's good if they maintain a diary. Then pill counting, and you involve the patient. It's very important that if the patients they are included as active partners, the disease control is much better. Like for unintentional non-adherence, keep the medication where it cannot be missed, like the TV remote control. You know, when they are going to switch on their TV, they tend to remember that, yes, I have to take my medication. Or near the refrigerator, like they want to get a bottle of water and they remember that they have to take the medication. So keep it at a convenient place where they do not, everyone has 2 or 3 things that they do every day without fail. So you can link it with that activity. Maybe near the spectacles of newspaper padne. Link it with some activity which they do. Put the medication in a place where it cannot be avoided when doing that activity, but always remember to keep all the medications available. Suggest that they can use an alarm clock. For example, if they take BP medication at bedtime or in the morning after the breakfast, or at bedtime 8 o'clock, they set an alarm that yes, I have to take medication at this time. They can use a small pill box. Each day they can keep the pills, and if it is missed, they come to know that, oh yes, I missed mine. So it will make them more aware about their own adherence. So such pill boxes are easily available in the market. If they can afford or if they are interested, they can buy this. And use of multiple medications and health tracks where the medications were taken. Sometimes you may need the help of a family member. Okay. So this is how we can, plan our interventions for unintentional non-adherence. For intentional non-adherence, we'll always have to respect the patient's choice also. They may not choose any medication, but yes, we have to discuss with them their recovery goals and make sure their decision is valid. They can simply not say that we will not do this. Asking the reasons for choosing not to take the medication. Sometimes they feel that I don't need it. Diagnosis ठीक नहीं है, मुझे कुछ नहीं हुआ. Blood pressure में, it's known as silent killer. The patient may not have any symptoms still. The internal organ damage is going on. So you have to tell them. बोलते मुझे तो कुछ हुआ नहीं, क्यों दवाई यूज करूं? You have to tell them that this is such a disease that it does not manifest as such, but so you need to explain the diagnosis. Feel their symptoms have been cured. This is the most common reason for non-adherence. BP अब measure करता हूँ तो अब तो ठीक आता है इसके बाद. So again, your intervention would be education and counseling. Sometimes they have unpleasant or problematic side effects. For example, fetal edema with amlodipine, मेरे तो पैर सूज जाते हैं, or any other kind of. So we'll have to see. We can change or we can suggest some. Fear that the medication will harm. Right? These are few answers that you are expected to give. And based on that, you will plan your education intervention. Objections or ridicule of friends and family, and feel like medication means they are not personally in control. काफी लोगों को वो लगता है नहीं मैं सैर से ठीक करूंगा, मैं योगा से ठीक करूंगा, हो जाएगा. It's difficult to accept that they need medication for a life. They don't want to accept it. So, and this category is also very, very common. नहीं वो मैंने वो खाया था आयुर्वेदिक दवाई खाई थी, मैं अब सैर करने लगा. You have to tell them that yes, these things help, but medication, the role of medication is very important. So you might get some of these points in the patients when you do their discussions. So if you find that there is non-adherence, try to explore these. You might find a reason, and that will become your area for intervention. Okay. This is the same thing. So what are the important messages on adherence? Ensure that the patient understands the benefit. We will not do anything which we don't understand any basis of. So to follow a practice, we must understand what's the basis. Choose lower cost medications and one that they are easy to take. Minimize medication side effects. Show the effectiveness of the medications in lowering blood pressure. Monitor medication adherence on all visits. This is very, very important. Monitoring of adherence to medication is very important. Another important component of intervention. So these are the interventions that you can choose, right? So you can choose one of these interventions, then implement that intervention as suggested, and then see what effect it has. The next intervention you can choose is self-monitoring and recording. Okay. So self-monitoring is very important in case of behaviors like physical activity, tobacco use, alcohol use. You can also measure weight, blood pressure monitoring, blood sugar monitoring. So monitoring of blood sugar and blood pressure are important in self-care. You can use a copy, you can tell them that keep a copy, a diary, or they can also use electronic apps. Now that some apps are available. So those that are, tech savvy, they can use some apps to actually monitor their adherence. And they should be able to understand and interpret, right? For example, BP findings. No? They are recording the BP. They should know this is high BP, low BP, or not. So if they are recording something, similarly for blood sugar, they should know that aaj mera blood sugar zyada hai. When they are recording, they should know what does this reading mean. So they should be able to understand and interpret so that they also feel that there is a need to modify their behavior. Right? So now that you are advising them, now what we will do, your intervention is planning for self-monitoring. You will have to decide on the device. BP machine hai, if they can afford a glucometer or not. You will need a person who is responsible. वो खुद करेंगे blood glucose monitoring, BP monitoring, or you need a family member, or they have to go to the UHC, or there is a local practitioner available. Sometimes in UHC, in that area, people just get their blood pressure checked from a chemist shop. There is a person who just checks their blood pressure and you have to identify who is the person from where. Ideally, it should be the same machine, same glucometer, same BP app, same weighing scale, because we are keeping a record. We'll compare, is it improving, is it worsening? So if the device is same, it is better. Then frequency of measurement. We should not overburden the patient. Whatever is feasible, that frequency has to be decided. And then recording it, diary, and where do you keep if required, you can draw the columns, day, date, column, BP rating, BP measurement, or blood sugar. So last intervention would be you decide behavior change and diet. So depending, are you able to, you have not done risk assessment. So otherwise by now, you should have been able to identify which key intervention you will do in your patient. So you can choose any of these, whichever is relevant to your patient. Right? Understand? The last one is the behavior change, that is diet and physical activity, and this is the one which is probably very difficult one to achieve. So this I think you have done already, right? So you have identified areas for interventions. So maybe you can find out if there were some good things and some not so good things. So if there are not so good things, that will form your area of intervention. So we'll probe for fruits and vegetables and salt intake. Similarly, we'll probe for unhealthy practices like sweetened drinks, papads, pickles, red meat, excess coffee, tea consumption, and then physical activity. So let us look at it in a little detail. So if you find that fruits and vegetables are not enough, so what key messages you would like to give? You have to tell them to include a variety of foods in your meal, a range of foods, whole grains. How much fruits and vegetables? At least 400 grams of 5 portions per day. One portion or one serving is usually one whole fruit, one orange, one apple. Similarly for vegetables, 80 grams. 80 grams of vegetables. So they should take at least 5 servings, fruits and vegetables. Now, potatoes, sweet potatoes or starchy tubers do not count as fruits or vegetables. So, potato will not be counted as a vegetable. So, if they have taken 80 grams of 1 katori of potato, it will not be counted as a vegetable. So, if it is aloo matar, the amount of matar would be considered as vegetable, not the aloo. Right. Similarly, if it's aloo gobi, the amount of gobi would be taken as vegetable. Tubers are tubers; they are not included in vegetables, right? So when you do your dietary assessment, be very careful that we will not include roots and tubers in vegetables. Only vegetable part, brinjal, peas, green leafy vegetables, other vegetables. Another important intervention would be dietary messages related to fat intake. So our total daily energy intake from fats should be less than 30%. As you already know, unsaturated fats are preferred to saturated fats. And less than 10% of the total energy intake should come from the saturated fats. Trans fats should be avoided. What are trans fats? What are the sources of trans fats in our daily life? What are the sources of trans fats that you would like to tell the patient to avoid? You will not tell trans fats. You will tell them, you have to tell them the food items, the sources of trans fats. What are the common sources of trans fats? Manu? Polyphosphated vegetables. Biscuits, processed foods, they usually have vegetable. Biscuits only. Or vanaspati oil, sometimes, people who eat from outside, the vendors usually use vanaspati. Another important intervention for hypertensive patients will be salt intake. So the simple messages, these are the key messages that you will use when you do behavior change communication. Right? So you have to choose your messages very clearly and carefully. So recommended is less than 5 grams of salt per day. Avoid adding salt while cooking or eating. Reduced salt contained in foods such as processed foods and bread. Avoid high salt content products like pickles, papad, bhujia, chips. These are concentrated salt. So they should avoid these. Similarly, the message for sugar intake should be very clear. हम उनको simple बोलते हैं नमक कम खाओ, चीनी कम खाओ. They are confused. They will not understand. कितना कम खाओ, कितना खाओ. That is to be very precise and clear. So precisely, total energy should be less than 10%, means almost 12 teaspoons for a person of healthy body. So for additional health benefits, less than 5% of total energy intake from sugars is fine. So from our total calorie intake, free sugars should not contribute to more than 5%. Clear? Now, any doubts still? From assessment to choosing your intervention? Anything which is over how we are going to remember? Anything which is not clear, we will be able to do. So now we are proceeding to the last of adult at least 150 minutes of moderate physical activity, right? Spread throughout the week. 150 minutes of moderate physical activity. Now, which activities are the moderate activities? These are, they lead to a mild increase in the heart rate or respiratory rate. For example, brisk walking, climbing stairs, dancing, gardening, doing household chores. These are moderate activities. And for moderate activities, the recommended duration is 150 minutes per week. Whereas if they engage in some sort of vigorous physical activity, the recommendation is at least 75 minutes of vigorous physical activity. And this would be running, fast cycling, swimming, or playing some sport. Spread throughout the week, or an equivalent combination of moderate and vigorous. Muscle strengthening activities involving major muscle groups, 2 or more days. Right? So these are the recommendations: 150 minutes for moderate activity throughout the week and 75 minutes of vigorous activity. And I think you were shown very clearly what are, when assessment was told to you, what are moderate activities, what are in detail. So educational intervention would be, you are required to prepare an education pamphlet. So you, as I told you earlier also, you'll have a full session on how to prepare the education pamphlet. So all of you, once you decide your intervention, you will have to prepare one and it will be evaluated. It will add to your internal assessment of your FHS. So this pamphlet activity has to be taken this intervention has to be taken very seriously. So one side you will educate about the disease, the other side on the behavior that you have identified to be changed and how. For example, अगर आपने adherence किया है तो आप, the second side you will put adherence. If you have some intervention on increasing physical activity, you will put that intervention, the key messages which I have just told you, on that side. And plan your behavior change intervention. So assess in what stage of behavior your case is and use appropriate intervention strategy. I hope you know what are the various stages of behavior change communication: pre-contemplation, contemplation, implementation. No? Pichli bari padhaya tha, all forgotten. So you have to see, pre-contemplation is they don't know, they are not thinking about whether they will adopt your plan. Contemplation is they are be able to convince them that they are actually thinking, yes, I can do this. I will start talking. Then you actually get the plan, then implement it, see their adherence, and it will better. So you have to see which stage your person is. So these are, in case you choose tobacco cessation, these are the 5 A's of tobacco cessation: ask, advise, assess, assist, and arrange. So these are the counseling: ask, advise. I think you can see this already. Similarly, the 5 A's model for client-centered physical activity. So you have to communicate freely. Discussion is the key. Communicate freely, use open-ended questions, address their feelings and provide support. Also try to understand if they have any misunderstandings or barriers. Provide correct information. Address barriers to change. Like, for example, the time is not convenient. She is busy in the morning. She has nobody to take care of the child. Try to identify the barriers and then try to address those. Encourage use of supports and coping strategies. So, like, as was discussed in the last session, having a partner to walk, taking somebody along. Now you tell them the various options that are available and then assist in choosing the option. Whether they would like to, begin walking in the evening if she does not have time in the morning, Potential resources and supports. For example, if your spouse is interested in exercising with you, if your neighbor is interested, and then recommend a documentation. Tell them to maintain a diary. आज मैं walk के लिए गया, आज नहीं गया, आज yoga is not included in physical. आज cycling किया या नहीं किया. So whatever they maintain to see how many days in a week they miss it. Then arrange follow-up because you have to monitor it. And this is, I think you have, this page is there in your modules also. This is how you are going to ask, advise, assess, assist, and arrange for fruits and vegetables. Similarly, ask, advise, assist, assess, assist, and arrange for physical. Now, this is one of, once you start, once you've decided that you will work on the physical activity of your patient. So you can simply start with, क्या हम फिजिकल एक्टिविटी के बारे में बात करें. आपको पता है कि आपको फिजिकल एक्टिविटी करना क्यों जरूरी है. क्या चीज नहीं पसंद आपको, क्यों नहीं कर पाते. सो इन्वॉल्व द पेशेंट, कम्युनिकेट फ्रीली एंड डेवलप अ प्लान. So this is in nutshell everything that we have discussed. The key focus of the program, detailed intervention plan to be prepared, what activities, by whom and when. So treatment goals and targets. So at the end of 1 month and at the end of 3 months, what is it that your outcome will be? Maybe the pill count improves, maybe the adherence improves, maybe the days of missed pills are less, maybe the days of less physical activity where they do not do physical activity are reduced. Maybe the BP is maintained at less than 140/90, right? The blood sugar is controlled. Okay, so these are your treatment goals. And in case of a child, the diet has improved, the dietary habits have improved, the wash strategy, hygiene practices have improved. And then monitoring mechanism, you can, the patient can do it himself or herself by the means of a diary. The family can be involved. You have to do and visit. So this is again, right? This is a physical activity plan. Why, what, where, when, and right? 5 W's and 1 H. How? The other one is how. Okay. For example, you have a patient with diabetes. It may be simply more energy. Why should I do physical activity? What kind of physical activity? Be walking here. So you have to make this. If you are planning a physical activity, what, where, कहाँ करें? कई लोग वहाँ जहाँ कौन सा पार्क है? There is one in Jahapana forest. Yeah. Some people go there for उनके पीछे है. There's a garden Jahapana. Or sometimes there is a park near that. So they have to identify a place where they when. So they may even say कि सब्जी लेते जाते टाइम कर सकते हैं, बच्चे को ले रहे हैं, या they actually take out some extra time for that. And who can you be active? They may find a partner, they may not. All by themselves, or with the spouse, or with children. Okay, so this was about the activities. All of you have an adolescent also allotted to you? No? Most of you have been given an adolescent, and let's quickly go through the adolescent interventions also. Screening, awareness, brief intervention. I will not go through these things. So these are the stages of behavior change that I was telling you. Pre-contemplation, contemplation, preparation, action, and maintenance. Now, some important areas of intervention that you might find in the adolescent case allotted to you might be like one, maybe the screen. You find that the screen time is way too much. So these are some important messages for screen. You can tell them to swap interactive screen-based activities for active outdoor. Can somebody just sum up what we did? First of all, we want to identify this is an extra contact. So as we have identified some points for intervention, we have some one by one we discuss. Of course, important ones are simple, reptile, physical activity. These are important. In addition to these three areas, what would be the other areas? Your measures in relation to what? You can begin sexual. Two sexual. So broadly, these would be the question. And I will be quickly telling you some things in case of. So we can tell them that it is very important to have a screen-free bed. They should swap it with physical activity, active outdoor activities. No screen during meal times. These are important messages. So, khana khate time there should be no screen. And no screens after a certain time, say after 10 o'clock, I will not look at my mobile. Have 1 day a week with no screen, like screen-free Sundays. These are just some messages that you can do. Notifications can be turned off. Parents can be asked to be good roommates. Use of substances. We have to tell them that these are, they'll make them dependent. These are habit forms. Once they start, because sometimes they just start it as an experiment. So we have to tell them that, it's not an experiment. Once they started, these are habit forming and they can actually fall into this trap for the life. And while under the influence of alcohol or other substances, people do things that they would not normally do, like driving dangerously, being physically or verbally violent. If they are otherwise not violent, but once they take alcohol or some drugs, they have some erratic behaviors, which has a lot of social and economic implications. So we have to tell that many adolescents die from motor vehicles crashes under the influence of these substances. That why they should not start consuming this even on an experimental basis, right? So if we tell them this, then sexual activity. So in some adolescent, it begins during adolescence, and they are at risk of unwanted pregnancies and STDs. So they should know what their bodies are going through. They should also need support to deal with their thoughts that accompany growth and development in order to make well-informed and so these are some messages. Learn and respect the traffic rules. Always use a seat belt. Always use helmet. Now, many of them have not achieved the legal age of driving. They would not have a license. So tell them that until you have a license, even a learner's license, you should not take to driving. Violence and abuse. Talk to your parents. Try to avoid in places where they may experience violence, and learning to say no. If somebody is trying to indulge in some sort of sexual activity, so this is known as life skills education. Saying no. So learn to say no where you have to say, and they can communicate it if they are experiencing some sort of bullying or some such behavior where they are being forced into, they should communicate it with their parents or any other responsible. Stress and loneliness, spending time, some physical activity. Do not use tobacco or alcohol if they feel lonely. And they need to seek help from a health worker if they are sad, anxious, or feeling every day, have sad thoughts every day for many days a week. Now, amongst girls, menstruation practices are very important. So we have to address the myths and facts about menstruation. Some people think girls are impure during menstruation, while the fact is that it's just a natural physiological process. Then buying sanitary pads should be kept private and covered in paper. But the message that we are going to give them is it's like buying any product for personal hygiene, just like soap. So we have to destigmatize the menstruation. Okay, so these are some common myths and misconceptions. I think we've already, many of you must be aware, but these are the myths, these are the facts. Girls having their period should sleep in a different room, and menstruation is not contagious and does not cause harm to anyone else. So these are the messages. If they think, the girls might be thinking that I should not be sleeping in this room, so you can provide them correct knowledge. Foods like curd, tamarind, and pickles disturb the menstrual flow. So we'll tell them the foods do not decide. Any form of physical activity can disturb the menstrual flow. Rather, we should tell them that exercise and playing sports can actually help relieve the dysmenorrhea or pain. So, menstrual hygiene is very important. We have to tell them to change the sanitary pads regularly, wash the genital area, so keep the area dry, regular change of napkins to avoid infections, and unhygienic management can result in reproductive tract infections and UTIs. So why is it important to maintain menstrual hygiene? The messages should be very clear. So these were the key in adolescent. Any questions? Anything that you need to ask? You can ask, please. Any doubts? Any questions? No? So you will be able to try on this now. Yes. Thank you. If you still have any questions? 15 ऐसी रोल नंबर बता 34 अच्छा अपने फ्रेंड्स को बोलो कि उसमें डाल दें अपना रोल नंबर्स ना 351 54 बोल दिया उनको जस्ट आस्क देम टू पुट देयर रोल नंबर क्या नहीं वो बोल देंगे ना मैं टेक अ स्क्रीनशॉट
After that, stop.